decided when I was in year 12. I think for a 17-year-old to have a clear-cut vision of what they want to do when they're older is a big ask. I ended up choosing a double degree of nursing and psychology, which seemed to fit all my interests really well. And then after uni, I applied to do my graduate year as a nurse at the Royal Children's Hospital Adolescent Unit, because I'd always, for quite a long time, had worked with teenagers teaching music and dance, and I really liked that age group. And I still actually quite like working with that age group. And then, so the adolescent unit at the Royal Children's, where I did my graduate year, is the medical ward where young people with eating disorders are admitted. And I think from there, I started learning how to care for young people and their families with eating disorders, and kind of my passion grew from there, because I saw how at times difficult it is for families to look after their young people, and also how misunderstood these young people are sometimes. Not so much now than 15 years ago, but I think it is still a problem. And then through the last 15 years, I've worked in different roles within the adolescent ward. And in 2017, I started working as one of the clinical nurse consultants for eating disorders in the adolescent medicine team. I think this role is brilliant because it allows me to work between the outpatient and the inpatient services. And so it provides a bit of continuity for families that are going in between. Yeah, definitely. I think I also have done a graduate diploma in adolescent health and welfare. And so I think the graduate diploma added onto my psychology knowledge and made it a bit more adolescent specific. And yes, I definitely use my psychology work in this role. I think it's an age group where a lot of people will kind of think you're crazy for wanting to work with them, because they're often quite challenging, but I actually think it's also a time of opportunity where there's so much growth and development happening that, you know, a positive influence can go quite a way sometimes. Young people with eating disorders are looked after on an adolescent medical ward here. And the role of the bedside nurse is so important, because they're the ones that are there during the meal times, they're there during the distress and are sitting with the young people through everything that's going on for them. And they're also there during those opportunistic times. So I often found working on the ward late at night, sometimes it was a time where young people would feel a bit more relaxed and able to talk about what's going on for them, and being able to be there to have someone to talk to is really important. And also times like when families are starting to do family meals in preparation for discharge and need someone to talk to debrief about how the meal's gone and if what they did was right or wrong, and just being able to be there to have those conversations is really important. And I also think the bedside nurse is a wealth of knowledge for the rest of the treating team, because they can actually describe really eloquently how the young person's going during meal times and the level of the distress they're experiencing, and it's really valuable knowledge for the rest of the team that aren't there all the time to be able to pick up on. The role that I'm in at the moment, the clinical nurse consultant role, it's often described as the glue for the eating disorder team at the moment. So we do a lot of different things. We coordinate the service overall, but we also do the intake and the triage, and we do education for both in-house people that are starting to work with the team and new people on the inpatient ward, and also external services we go and do education for sometimes. And we also play a role in supporting the patients and their families throughout the inpatient and outpatient services. And I feel like in this role, I'm able to advocate for best care for young people and their families more, and, you know, support them through one of the most difficult times that they're going to be going through. There's no quick fix. I think families often come to an eating disorder service, you know, wanting to find out the information or what they have to do to help fix their young person. And, it's really difficult because there's no medication, there's no surgery, there's no, week on an inpatient ward that's going to fix what's going on for the young person. It's often a really difficult, long journey, and that can be really hard for a lot of families. And I think to add on to that, the best evidence-based treatment for young people with restrictive eating disorders being family-based treatment is a really big ask, and it's a difficult task for families to take on. And I think it takes so much kind of time and determination and strength and patience for families to get through the family-based treatment process. Some families it's a bit easier for, and other families it can really take its toll, especially when there's competing needs within the families, with other things going on, which especially this year there's been a lot going on for a lot of families. Another challenge in terms of professionally is seeing families in such distressing times in their lives, and it can sometimes feel really heavy. And I think as professionals, we've got to make sure we're looking after ourselves as well, because it can sometimes feel heavy helping families and young people through such difficult times. I'd have to say initially the team that I work in. I think it's so important to feel supported in the framework of your team when you're doing work like this. And I think specifically in our service, the mental health clinicians and medical clinicians work so closely together. It provides a really supportive framework for everyone to feel like there's a lot of collaboration together. And there's always someone to bounce an idea off or debrief with, or kind of just work through things with. I think that's really important. And also, I think it's really valuable working as a team with families. So I think part of what an eating disorder service does is they provide that team for the parents who are doing the FBT. So, they've got the doctor and the mental health clinician, and the nurse can often provide the sounding board or the debrief type role for families who are really struggling, and kind of provide some of that supportive structure for the families to be able to lean on when they need to. Definitely value when we hear from past patients, if we get a letter or an email saying, hey, we've come out the other side, and telling us about the amazing young adult they've turned into, and all these brilliant things that they're doing. That is definitely really nice to hear sometimes. In general, it's mostly parents that will identify that there's a problem. We do often get calls from schools, like school nurses and counsellors, saying, I'm really worried about this young person. But that's less often than the parents initiating the GP appointment. And we'll often get calls from parents just from the website saying, I just want to find out, this is what's happening for us, what should we be doing, how should we navigate this system, because it's a really difficult system to begin to navigate. In terms of coming into our service, the main way you come in is you go to your GP and get a referral to our service, and on our website there's some guidelines for what we'd hope the GP would include in the referral. And the other avenue that some people take is just presenting directly to our emergency department if they're worried about their young person. So it would either be a GP referral to the eating disorder service here, presenting to emergency, or just calling the number that's on our website to touch base and get some advice as to where to for your particular circumstances. For the first inpatient admission, it generally lengthwise will be between 1 and 2 weeks of needing to stay in hospital. We generally wouldn't admit someone to the inpatient ward unless they're medically unstable. So we'd be looking at things like heart rate and blood pressure and blood test results and things to make sure they're at a safe level to be able to be discharging home. So during the inpatient stay, you'd be initially often needing to be in a wheelchair to maintain safety if you've been feeling dizzy and at risk of fainting and things like that. And you'll be doing meal therapy on the ward with the nursing staff supporting. And then as you progress through the admission, you will, when your blood pressure stabilises, you'll be able to come out of the wheelchair and be walking around and engaging more activities. And further on towards the end of the admission, we start encouraging parents to come in and do the meals with their young person to start preparing for home and having to think about what home is going to look like upon discharge and figuring out what treatment's required and organising treatment to hopefully start soon after discharge. When people are coming in and out of hospital frequently or require really frequent reviews in the outpatient service, it's really individual based on what they need. Some people will need weekly reviews for a while after they're discharged, and we need to provide that to be able to support the young person and their families to be able to stay at home. Some young people do need multiple admissions before they can progress to being able to stay at home, and we just talk about that in terms of, okay, we've got to try at home, and then if it doesn't work this time, we can bring you back in, give you a bit more support, then we'll try again. And it's not a failure, it's not anything that you've done wrong, it just means that maybe we need to give you a bit more support and then we'll try again at home. But I think we will often respond quite individually to cases that like that we need to give a bit more intensive support for. In normal times, but with our normal FBT service, when families are discharged, they'll have 2 sessions a week with their family-based treatment clinician for the first 2 weeks. So it's quite intensive for the first 2 weeks, and then weekly appointments after that for quite a while. In addition to that, there'll be medical reviews. So we'll often have a medical review the week or 2 after the young person's discharged, and then at least monthly after that, if not more frequent, depending on how everything's travelling. So it is very different, the support from the inpatient ward to the outpatient ward, and that transition can often be really difficult for families, which is why we try and encourage, families doing meals in the hospital, the inpatient unit, to start getting a bit more prepared. But then in between those appointment times, there's always Stephanie or I, the other clinical nurse consultant, we're always at the other end of the phone during business hours if families need some extra assistance.
Yeah.
It's really difficult, and it is something that can be, in the inpatient setting, it can be difficult for nursing staff that are new to the ward to feel comfortable to be able to do. So we do quite a bit of education for new staff on the ward to support them in doing that. Having said that, even education for the inpatient unit has been difficult this year due to COVID, so it's another thing that's been made more difficult. And then, so in terms of the inpatient ward and the meal support, we've got quite clear guidelines of what is and is not okay during meal times and what the meals actually should consist of. So there's very clear boundaries and guidelines, which I think is really supportive for both patients and staff. In terms of supporting families in starting the meal therapy when going home, I think initially that practice while the young person is still in hospital is really important, because they get to see what food the young person's actually getting served. So the practicalities of, oh my gosh, what do I have to feed my child when they get home? That can be a really daunting thing for parents to be facing. So they get that exposure to what's actually been happening. And we often say in the first steps when you bring a young person home, trying to recreate what's been happening in hospital at home is really beneficial, because keeping those boundaries can often feel safe for the young person in the change from hospital to home, because it just can provide that continued containment, if you want. And then in terms of the individual support around meal therapy for families, that will often start when the family-based treatment starts and the clinician has the one-on-one sessions with the families and get to know the individual dynamics of what's happening within the family. Because I think we can provide overall support and advice for families as to how the meal times should work at home, but it often needs to be quite individualised, because every family has different dynamics and different strengths. Yeah. We do have a list of resources that we give to parents in terms of, websites and books and things like that can be really helpful in, being able to get their head around and learn the basics of what to expect from family-based treatment. Yeah, it's hard to prepare a family for, to be honest. Letting them know that it's going to take a bit of hard work, but it's not going to be a short 2-week thing that they need to put in some effort for. It's probably going to be months of effort, but also we talk about laying the groundwork in that first couple of weeks when you first come home, and having the boundaries and the support intensive from the start within the home can be really good to kind of lay the foundation of things going better over the next coming months. I think also giving a bit of education about why we're so worried about this eating disorder and why it's so important to get onto it as early as we can. So making sure families understand, what this eating disorder is, why we need to get onto it early, what the potential effects to their young person could be if they continue not to have adequate nutrition. So making sure that that understanding is there, because in the general community, a lot of people don't actually understand the effects of lack of nutrition on the body and the long-term consequences that it can have. It's really hard to quantify. I think my gut feeling is yes, but it's hard to quantify, because I think it's quite a general thing that social media is making the lives of young people overall more complicated, and the idea that young people are taking their phone to bed with them and being accessible to their peers 24/7 and not being able to switch off and just have that time away from the pressure of being who they want to present themselves as. So I think that definitely has had an effect. We've always had the view that on the inpatient ward, because it's a general medical ward, we will support parents in taking away access to devices if they think that's appropriate, and we've been leaving it as a parental decision because that supports the FBT framework of the parents are the ones that are in control. And also there's been questions if it's fair to take phones and devices or limit access to phones and devices to one patient cohort and not the rest of the ward. Having said that, there's been a lot of team discussion around it, and at the start of the year we decided to bring in some limitations around use of devices in line with the public school guidelines, because public schools in Victoria have this year limited phone access during school times. So we decided to bring that in conjunction with that. But then we brought that in for about a month, and then COVID hit and everyone was really isolated and needed their devices for school. And so that went by the wayside because we had to accept that it was probably more important for people to stay connected and be able to access their peers. But in the last month, we've started bringing that back in terms of limiting use of devices. So I think overall COVID-19 has had a really significant impact on adolescents worldwide. I think especially adolescents that have got pre-existing anxiety or mental health troubles already. And I think we've seen, not just in Victoria, but from services throughout Australia and worldwide, that the numbers of new diagnoses of young people with eating disorders has risen a lot. I think within our service, since May, our number of new referrals and new patients needing inpatient admissions has doubled. We've had to initiate a wait list to start treatment for the first time ever, and we've also more recently had to reevaluate how we provide assessment and treatment in our service, just in order to be able to provide timely treatment to families. And even that change has required extensive coordination and resources to manage changing how we're delivering our service. And I think for young people, a lot of what we're hearing is that, you know, all of a sudden with COVID-19, their framework of school and extracurricular activities was gone. And so their outlets and their distraction was gone. So that a lot of young people were left with their thoughts and left, you know, with a lot of time to wonder about what they should be doing. And, you know, maybe young people were using a lot more social media if they had more time, and, you know, potentially some families or some young people weren't able to have as much adult supervision with school taken away and parents needing to figure out how to work from home and help their young people do school from home, and all the change happening all at once. I think it was really difficult for families to navigate that, and teenagers being left to do homeschooling was really difficult for a lot of young people. We're still hearing the stories that it's still coming through of it all began when lockdown started. And the more recent referrals has been young people that have gone back to school, and people have all of a sudden realised that things maybe aren't so okay with this young person. So yeah, with lockdown ending, it's probably more to do with more people realising that things aren't okay and feeling more able to access services now, because a lot of people were trying to stay away from hospitals, understandably, and now people feel a bit more comfortable accessing services. But it's interesting what you said with people working from home. For some families, there was more adult supervision, and so we did initially see that families already doing family-based treatment actually could do it easier because they had more access to things like telehealth. They weren't going to and from everything, so there was more time in general to be able to focus on getting the meals done. It's definitely busier. There's more referrals and more intake and phone calls to be doing, but there's also more of all the other parts as well. So it's not, I wouldn't say it's overtaking what we do, but there's definitely a lot of it to be done. And I think that given that there's often more of a delay in waiting for assessment and accessing services publicly or privately, I think that initial contact is probably more important to give as much information as you can and give as much support as you can during that initial contact, because there is likely to be a bit longer of a wait time, and giving parents that support while you're on the phone is important. On the inpatient ward, there was really strict restrictions on who could visit. It was only one parent for most of the year. That's only recently opened up to siblings being able to come in. That had an effect on things like parents doing family meals on the ward because parents couldn't do it together. There was only ever one parent able to do it. Also things like during meal therapy, because we had quite a lot of patients in at one time, sometimes we had to have 2 groups during meal therapy at different times because the person per square metre capacity in the room that we do the meals wasn't able to hold that amount of people. Also things like the family meetings that we do once or twice a week on the ward to touch base with families and provide them with an opportunity to get information. They went to telehealth because obviously the team and both parents couldn't fit all in the meeting room together. Yeah. So there's quite significant changes from that perspective. And then in our outpatient area, we've also been doing all of our appointments that we can on telehealth. So for most of the year, unless anyone physically needed a review, we'd be doing telehealth appointments. And our intake assessments, where the team would assess and diagnose a young person, were also done via telehealth, which technology always presents its own challenges with, you know, people being on mute and screens freezing and things happening in the background. So it was very difficult to navigate initially. We've gotten used to it, and I think we've moved we've definitely moved back to more face to face, and we're just, you know, navigating it as in the safest way possible. For FBT sessions, we would have the parent do the wait at the start of the FBT session, but while the clinician was on screen, so that they could support with any distress around the wait. And that has been a big change because that's something that we'd always discourage families to be doing, waiting their young people at home. And we've also been collaborating much more closely with GPs. We've been asking GPs to be doing weekly vitals and weigh-ins for a lot of patients. And that's actually been really nice to be developing more of a relationship with the GPs for the families. And I think moving forward, it'll actually be quite protective for these young people to have a good relationship with a GP that they feel able to talk to. So yeah, the weigh-ins have been either at the GP or at home, depending on the situation. And then, as I said, some patients we've had to bring into hospital throughout the year if we've felt it's not safe enough for them to be assessed in the community. So generally, the GP will refer to us, we'll do the assessment, we'll send a report out to the GP saying, you know, we've diagnosed this is what we're planning on doing, and we'll hold the medical care while the young person's going through treatment. Yeah. And then at the end of treatment, we'll discharge back to the GP, or we'll hand over more of the medical reviews to the GP gradually while the paediatrician extends out their reviews. So generally during treatment, we haven't really utilised GPs anywhere near as much. And I think a lot of GPs have been really valuing being more involved in the process and getting a bit more of an understanding about what's happening. We've developed a pretty comprehensive letter that we send out to each GP that's looking after each of our patients to make clear what our admission criteria are and the contact numbers and all that kind of stuff. In terms of coming into the inpatient ward, I think 9 times out of 10 when I'm supporting a young person through their admission onto the ward, they will be so scared and so unsure about what's going to happen, and they've never stayed in hospital overnight before, let alone, you know, for treatment of an eating disorder, which they're not even sure if they have, and it's just a petrifying time for them. But I think what's good for them to know is 9 times out of 10 again, when I go back and see those young people a couple of days later, they'll say to me, "Oh, Claire, I was so scared a couple of days ago, but everyone here is so nice, and, you know, I know that they're here to support me, and I know that they're doing this for out of my best interests and out of concern for me. So just letting people know, as daunting as it is to have an assessment or to come into hospital, and I'm sure there's all these horrible things you've got in your mind that might happen, it's actually a really supportive process, and everyone's there just to support you get through this. Sometimes it takes time, and it can take those, you know, going home and coming back in, and going home and coming back in, and sometimes that's what's needed to help get a bit of momentum in treatment. I think the biggest thing, especially over this time, is to try and find those moments of joy in between the difficult times. So to try and find that connection with a young person, try and do something that you do every year over summer holidays that you know brings your family joy. Trying to, just get those moments of joy where you can, because it is really difficult and it's hard and heavy a lot of the time. So try to work on those in between times when you can to get those moments to reconnect and enjoy things as a family. So historically, if there's an important event for a young person, we would always aim to either give them some leave from hospital or have them discharged by the time there's an important event. That will always depend on medical stability and if it's safe for that to happen for the young person. So that would be our initial aim. And then secondarily, we will often support young people and families to celebrate certain events. We've had a family use our recreation room to have a party for a young person before who had been in hospital for quite a while. And for patients that do have birthdays on the ward, the nursing staff always do celebrate with the young person. Things like the big holidays like Easter and Christmas, as a hospital we'll always celebrate that. So the Easter Bunny comes at Easter and we'll give some treats, and Santa Claus always comes at Christmas, and there's a beautiful big band that comes and plays around on Christmas Day. The hospital will usually provide a lunch for families, so parents and the young person who's in hospital will be able to go downstairs and get a Christmas lunch to be able to all enjoy together. Difficult time because it's time when a lot of so we've got a school program that runs most of the year, and the school program is on skeleton staff usually during the Christmas holidays. We do have a group called Livewire that come and are really great with helping with distraction and engaging young people in games on the inpatient ward. And yeah, it is definitely a quieter time on the ward, and there's a lot of patients do report feeling bored and just wanting to be out hanging out with their friends, and it can be really hard. So yeah, as I said, we always aim to not have young people in hospital for any longer than they actually need to be there, and providing day leave if we can, or just discharging as soon as we can to get young people back into their home environment, being able to engage with their friends. Young people can have friends visiting on the ward depending on what stage of their inpatient treatment they're on. We usually say initially it's not a great idea to have friends coming in just while you're getting settled, but then later on in the stay it can be really helpful to have some friends come and visit. I'm happy here for the moment. I think working on, the things we can develop within this service is my passion at the moment. I remember from when I was in my grad year talking and had first started looking after young people with eating disorders, I remember talking to my family going, I think my dream job would be doing, care coordination for these young people, because I think we could actually make a big difference. And, I think, yeah, I think just working on this role and being able to be the best clinician I can at this time.